I'm going to give the first talk, and then I'm going to try to stay out of the way most of the rest of the day for the rest of the faculty. And I think this will be the last talk I give that has the OHSU logo, which is still my current employer. Thank you. So here are my conflicts. None of them are really related to this issue. So proximal junctional failure is a common complication in adult spinal deformity, and it is one that we are seeing increasingly as the numbers of cases that we do continues to increase as well. This talk is going to go through a bit about the definition of what we mean by that phrase, proximal junctional failure. We'll talk some about the risk factors. There are patients who are more likely to develop this complication than others. And we'll talk about the mechanisms by which this occurs. And finally, some discussion of how we might think to prevent this and reduce the rates in this patient population. So what is proximal junctional failure? I still remember, actually, I don't know if it needs to be on or not. There, is it back on? So I still remember actually the first talk I gave on this at either IMAST or SRS, and David Polly after the talk collared me and congratulated me on creating a new TLA, which is a three-letter acronym. So PJF is, of course, related to proximal junctional kyphosis, but we use the phrase proximal junctional failure to distinguish a complication that is really more common in adults than PJK is. PJK I think of as really a recurrent deformity. It was initially described in pediatric patients, and I think initially in a Scheuermann's disease population in which patients developed new kyphosis above the top of the construct. Tom Lowe, I think, came up with that phrase initially. And it is proven to be relatively benign. It typically does not progress. It typically does not create a need for revision surgery, and it does not have measurable impact on clinical outcomes. Proximal junctional failure, on the other hand, includes not just deformity, but some form of mechanical failure. And typically, there's the first harbinger of it is a compression fracture of the vertebral body, usually the upper instrumented vertebra or the upper instrumented vertebra +1, and then additional portions of the construct or the vertebra can be fractured or injured as well, and that leads to, in the worst cases, a mechanically unstable situation. It's been referred to as topping off syndrome. That was a phrase that John Kostwick used. Proximal junctional fracture and fractures above all pedicle screw constructs are in the literature. Both of those were out of WashU. And really, proximal junctional fracture, we think, doesn't completely describe the phenomenon because there are patients for whom this is mainly a soft tissue failure or a hardware failure. And proximal junctional acute collapse was a phrase that I used in a paper about 10 years ago, but I think proximal junctional failure is a more concise and hopefully complete description of the phenomenon. And it's been described in a number of series, and this goes back to 1999. There's a number of studies since then. The Etabar paper was dedicated not just to this complication, but to proximal junctional pathologies, but clearly showed at least one or two cases of fractures above longer constructs. And again, I think since that time we've been doing more and more of these surgeries, and therefore the recognition of this complication has continued to increase. And recent estimates of incidence, kind of updating those papers, the Lau paper from the Adult Spine Deformity Committee of SRS showed an incidence of somewhere between 5 to 40%, with revision rates among patients that have the complication of up to 50%. Dr. Bridwell out of WashU showed a prevalence of up to 40% and did show a correlation to pain scores. Mauro et al. Is, again, an incidence of 40% and a revision rate of 13%. Rich Hostin in the ISSG data showed a lower incidence of 5.6%. But I tend to think that that is probably an underestimate because it was a retrospective cohort where surgeons were trying to remember cases and include them. So I think that's, first of all, probably the higher end pathology cases, and second of all, the denominator may not have been completely accurate. So I believe that's probably an underestimate of the actual incidence. And this is an example out of my own practice, and one of the worst that I've had now, a woman that we did an anterior-posterior operation on for flat back and non-union over a prior construct, stopped at T10, and I was happy with the alignment early on. She was doing well clinically, but then had a ground level fall at a nursing facility and came in on a stretcher with cord compromise and partial paralysis. She recovered the ability to walk, but of course the effect of the myelopathy never goes away completely. And obviously this is something we need to understand better to avoid this kind of risk for our patients. So what are the risk factors? Age is clearly one that's been demonstrated in a number of studies. Use of PSO for correction, as well as the extent of the preoperative sagittal imbalance. And then in addition to that, the operative change in the lumbar lordosis and the PI minus LL mismatch. So if you think about all three of those, they probably travel together, right? So if you have somebody who comes in with bad sagittal imbalance, you're more likely to do a 3-column osteotomy, and you're of course more likely to create a lot more lordosis than they came in with. So all of those come together. So these are patients, older patients that have bad sagittal alignment. That's the risk pool. And distal fusion to the sacrum is also clearly an independent indicator that's emerged in several studies. And again, there, if you think about it, that fits this patient population. So it's an older adult patient population with large sagittal imbalance requiring fusion to the sacrum. So those risk factors initially emerged out of work that the ISSG did, and they have been verified now in other single center studies. And there are some additional risk factors that people discuss. High BMI probably is. Low bone density, I think all of us would assume is, and I would like to say that we are sure. The problem is that we haven't had sufficient data to really prove the point, but obviously it's an issue, and I think you could consider advanced age maybe a proxy for bone density reduction. Medical comorbidities, again, some of these things travel together, so whether that's an independent risk factor, don't know. And proximal endpoint has been discussed, and there are authors who believe that thoracolumbar endpoints are more prone to this complication than upper thoracic endpoints. The ISSG data so far has not proven that out, but it may be that is also a higher risk stopping point proximally. So what are the failure mechanisms? I've listed here three that I think are the primary ones. So anterior vertebral collapse, we've talked about. That's a compression fracture, usually of UIV or UIV plus 1, and that in and of itself produces kyphosis, and with worsening injury, the kyphosis progresses to an even greater level. Hardware pullout posteriorly is a type of disruption posteriorly, and that can be an independent predictor of need for revision surgery as well. And then I think the issue that is, in my mind, probably the most dangerous and in terms of neurologic vulnerability, and also probably the most common, or when it occurs is a predictor of need for revision surgery, is posterior column disruption, and we're going to focus on that in a good bit of the rest of the talk. So we developed a proximal junctional severity score within the proximal junctional failure severity score within the ISSG, and this has been validated now by Chris Ames and Cal Kabesh, showing that revision rates correlate with higher scores. And we kind of borrowed heavily from the TLIX classification that developed out of the spine trauma study group several years back, which really creates a scale rather than a classification, let's say. So the 6 categories at which we assign points are the presence of a neurologic deficit, the severity of the focal axial back pain, the status of the instrumentation posteriorly, the change in the kyphosis, along with the proximal ligamentous complex integrity, and the type of fracture at the UIV or UIV plus 1, as well as the level of the upper instrumented vertebrae. That again was felt by some to be more concerning when these failures occur in the upper thoracic spine. Again, each of these with increasing severity depending on the extent of the disruption. But if you think about what we just went through, I think what emerges in my mind is the importance of posterior column failure, because you don't get translation, which is the high end of disruption in one of the categories, without posterior column failure. You typically don't get hardware failure without posterior column failure. Your kyphosis tends to remain at a lower level, so it increases the kyphosis when the posterior column fails in tension. There's certainly a lower risk of neurological injury without posterior column failure, and again, we've proven that there is a lower revision rate. So here's an example that's on the low end of the pathology, and this is a woman I operated on many years ago now. And at 2-year follow-up, she had not only a proximal junctional fracture and mild failure with a compression fracture, but also developed significant kyphosis due to what Frank Schwab and Virginie Lafage call reciprocal change or increased thoracic kyphosis. Not the most attractive X-ray, but she has never needed revision now, almost 10 years out, and she really has loved her clinical result as of the last time I saw her several years ago. So again, that doesn't always, if it's a minor fracture and the posterior column remains intact, it doesn't always lead to a bad clinical result. So what techniques do we have to try to reduce the incidence of this complication? So a number of these have been described. Vertebral augmentation is something that I did early in my experience and have written about. Cal Kabash has written about that, and I know Chris Ames continues to do that, a number of other surgeons as well. Some surgeons feel that proximal hooks as opposed to screws at the upper level may reduce the incidence of this. Again, some surgeons argue that moving the upper junction cranial may reduce this incidence, that upper thoracic is less vulnerable than lower thoracic spine. Some things I think are proving to be true include tuning our correction. So now we have a better understanding of the pelvic parameters and what those really require for a given patient in terms of lumbar lordosis. And if we match that well, we probably have a reduced frequency of this complication. And if you think about it, I think it actually matters if we undercorrect or if we overcorrect. So if we underlordose a patient, they're still going to have difficulty standing up straight, and that's going to produce added stress at the upper end of the construct. If we overcorrect and overlordose the patient, then they may want to come forward, and they may come forward through uninstrumented thoracic or cervical thoracic spine and again create upper junctional stress. Laying in of the rods to the upper screws is something in my practice that I think has definitely reduced the rate of this complication. By that I mean not contouring the rods on the back table, but using in situ benders to complete the reduction of the rods into the screws. So we're not reducing the spine to the rods at the upper end of the construct, just the opposite. We're laying the screws directly into the saddle so that there's no pull-out force as the patient lays on the table that sets them up for the potential for proximal failure. And limiting proximal dissection I think is critical, and we'll talk about that, but certainly preservation of the ligamentous complex above, and I think the less we do at the top, the better in terms of preserving musculature, and that's something Cal Kabash has also been focused on with use of percutaneous fixation at the upper end of the construct. Now, I have to say still at this point that we have a relatively limited data supply to demonstrate that any of these techniques truly work. I think it's coming, and certainly there is some data that vertebral augmentation reduces the complication. I think aside from that, tuning the correction is really the only other one that may be supported with data at this point. So here's a case example, and I use this to demonstrate that none of these techniques or many of these techniques aren't 100% effective. So this is a woman I did, again, a number of years ago, stopped at thoracolumbar junction, relatively small deformity, and didn't really change her lordosis much. And using cement at the upper junction here did prevent failure, but I think that may lead to an early trade-off of accelerated degeneration at the proximal junction, and she went on within 2 years to be very symptomatic from stenosis and axial pain from rapid degeneration of that proximal disc. And so at that point, we extended her up. And so I would call this a failure of cementation. Now we've moved the junction proximal, which is argued to be a benefit, and we've used upper hooks instead of screws. And in this construct, she did develop rapidly a true proximal junctional failure with pull out of the upper hooks and significant kyphosis, and that required yet another revision into the cervical spine. So this is obviously not the outcome we're seeking with these patients, and particularly somebody like her where preoperatively her deformity was really not an issue for her clinically, but really directed the need for fusion based on instability and a relatively modest coronal curve. So with that in mind, let's go back to the posterior column. So none of the techniques we've talked about really augment the posterior column. Certainly avoiding injury to the posterior column is important, but that doesn't strengthen it. Posterior column integrity, on the other hand, I think is proving to be probably a central focus that we need to be paying attention to. And so if we think about that, what techniques then are available and are described? And really, there have only been two that I'm aware of. One is the spinous process augmentation that Chris Ames has published on and that I've used now recently in about 15 cases with good success. And the other is rib fixation, which is something I've been doing over the last 2 years. And I'll describe the technique I use for that. And I'm happy to show both of these techniques in the lab if anybody has an interest. So we have done about 30 patients with an upper instrumented vertebrae +1 rib fixation. And so this is not a fused segment. We're performing fixation off the midline through separate fascial or in some cases through separate skin incisions with a variety of devices. And the first one I used was the Vector device, which is all metal, but is still quite pricey. And so I have gone away from that. That, of course, is an off-label use of that device. After that, what I began using is one of the sublaminar tethers that have been developed now and marketed by a number of implant companies, and instead of putting this in a sublaminar position, winding the Dacron or polyester tape around the rib and then attaching it to the primary construct, and we're able to tension that device, and that has also been fairly effective. And then I've also just used some standard sublaminar hooks that we've modified to create a claw construct that fits around a rib. That's shown on the lower right corner there. So all of these I've used all of those devices in this type of application. So why do I like this idea? So I think it reduces the extent of proximal dissection, which makes good biologic sense, less injury to the muscles, less injury to the ligamentous complex, and you're extending a level above your fusion. Mechanically, I think it makes sense because it extends the moment arm lateral, extends the length of the moment arm, and thereby provides better strength than a midline construct really can. It allows you to do other techniques. So if you still want to augment, you can certainly perform this as well. If you want to use upper hooks, you can still do that as well. It's independent of what you do at the midline construct. It does take some fuss in the OR. It's about at least 20 minutes additional surgical time, which with these long cases is certainly worth consideration. So this is a slide trying to show how we do this. The rib attachment, again, is at the UIV +1. We do it through separate lateral incisions. We use a blunt muscle dissection down to the rib, and then an offset connection down onto the main construct. And I've also been including a suture reinforcement of the spinous processes in some cases, either as a solo technique or augmenting this as well. So our experience with the rib fixation at the time that I put this together was about 26 patients, mean age of 68, 16 with metal implants and 10 with a softer tether. Again, these are a high-risk patient population. This is not a randomized, it's not even a consecutive study, but it's all patients that had a significant sagittal correction, older population, number with low bone density based on DEXA scans, and 2 of them actually with Parkinson's disease. And so you can see, again, large correction of SVA, large correction of pelvic incidence to lumbar lordosis, and all but 2 of these patients fused to the sacropelvis. And we had relatively few complications, one pneumonia, pulmonary complications, one pneumonia that I think was unrelated, one air leak that was definitely related, and then one pulmonary embolus, which was the only fatality in the perioperative period, and that I think was probably not related to the rib technique. In terms of PJF, we had about a 20% incidence of PJK or PJF, that should read 5 PJKs and 3 PJFs. So the total number of fractures was relatively limited, and none of these required a revision for either junctional failure or junctional kyphosis over now almost 2 years follow-up in all of them. And here's one final case example out of that patient population. You can see a heavy woman, advanced age, high BMI, and osteopenia on DEXA scan, multiple prior surgeries, and we did a 3-column osteotomy with actually a VCR and second stage anterior reconstruction, and she has done very nicely now past a 2-year follow-up without significant junctional problems. And that shows you a little bit, you can see the vector at the upper end of the construct. That's how we have typically applied that. So conclusions, proximal junctional failure, it remains a serious complication. I think we've gone a long ways towards defining the profile. We still need to work on methods to prove that we can reduce the frequency. I think there's no technique yet proven that eliminates the complication, and we're going to likely need multiple-pronged approaches, probably including biologics. I didn't talk about Forteo, but I think medication treatment preoperatively when bone density is an issue. And I think we really need to be paying attention to the posterior column and figure out ways to augment that as the next step in reducing this complication. So, thanks very much.